Welcome to SMA's Southern Medicine Podcast. Practicing medicine in the southeastern United States presents unique challenges for healthcare professionals. The South's heavily rural population and limited resources require medical professionals to be more resourceful in their approach to providing quality care. SMA's Southern Medicine Podcast addresses these issues by drawing on the experience of healthcare leaders who provide a multi-specialty, interdisciplinary team approach to medicine for the purpose of providing better care for the Southern patient population.
Today we're talking with Ryan Fahy, a general surgery resident in Connecticut. Ryan and I met at an ice rink in Pelham, Alabama, where we played beer league hockey together. Yes, we have hockey in Alabama. We crossed paths on a Facebook thread last week where we discussed the pandemic. We decided to take our conversation offline to learn about what he's experiencing and to take a peek into the research he's doing on COVID-19. So Ryan, thanks for joining us. So let's start with where you are now, what you're doing, the environment you work in, and a little bit about your training and your background.
Of course. So I'm Ryan Fahy. I'm a surgery resident in Connecticut. It's about an hour outside of New York City, east. It's a 396-bed hospital that I'm currently working at. I did my medical schooling at the Alabama College of Osteopathic Medicine. Did a year of general surgery at the Baptist program in Birmingham, Alabama, and then I moved up here to Connecticut and currently completing a PGY 2-year in surgery here. So, as I said, it's a 396 or so bed hospital. It serves as kind of kind of a unique population. So we get a very diverse representation of the of New York and of the surrounding area. So that's been one of the biggest challenges, is seeing a lot of the spread of COVID in this area has to do with people then end up bringing it back out here to Connecticut.
Yeah. So you're close to the epicenter, so to speak. I think the statistics were roughly half of the infections and deaths were in the New York, New Jersey area. So you're right there in that epicenter. So what was sort of like your first exposure to the impact, or talk about the impact a little bit, and just sort of when you started seeing patients and what you did to protect yourself, and then just how the virus was reacting and some of the things, because we were kind of messaging back and forth on Facebook about blood type susceptibilities to certain blood types and things. So I guess kind of back that up, but start sort of with your first experience with the patient and sort of what you're kind of seeing at the early onset of all this.
Yeah. So being a surgery resident, my happy place is in the operating room. So we don't like to take people to the OR, but it's what I want to do. That's what I enjoy doing. And unfortunately, all elective surgery has been postponed. And so what the initial impact was, the end of March, we saw all elective surgeries canceled.
Yeah.
And we were kind of put in a holding pattern as surgery residents because, if attendings go down and worst case scenario, no one can take care of a surgical patient, us residents were the only ones that could take people to the OR and, potentially save their lives if they need. So we were kind of put in a holding pattern and asked to just kind of sit on the sidelines at first. And then we started seeing the huge surge of patients given New York City's massive, exponential growth in cases. So once that happened, we opened up 3 dedicated COVID ICUs. And as surgery residents, we were asked to man 2 of them. And so I've been part of a team that's actually kind of an oddly diverse team, mixed with PAs, anesthesiology attendings, surgical, critical care attendings, everyone kind of being put together and asked to step up to the plate. And so currently, the unit I care for has 18 beds It's a team of 3 and attending, and then 2 other members, be it a surgery resident, a PA. We currently have not been mixing in with medicine residents because they've been manning their own COVID dedicated ICUs. So at the moment, we have approximately 40 beds for dedicated COVID ICU patients. And then the rest of the hospital is also partitioned in very weird ways. We have floors dedicated to people that don't need to be intubated. We have COVID rule-out floors. We have actually very little floor space left for the regular patients that comes into the hospital. Initially, and I started approximately 3 weeks ago on the dedicated COVID unit, and immediately we filled up. We had 10 patients right away. We had the extra spillover for the extra 8 or so patients that we could accept, and we'd been slowly filling up since then. We've been doing 4 days on, 4 days off to try to mitigate our exposure to the hospital. And how much we're bringing back home to our family. So
have you had enough of the protective equipment that you've needed to kind of deal with that? I know there was a lot of talk about not having the resources. Did you find you guys had what you needed, or?
That's a great question. And the answer is yes and no. So, we have the N95 masks that we need, which is always the big question. And we've been able to readily grab an N95 mask whenever we needed it. Actually, in between individual patients, we could do that. We had enough supply as of the last time I left the hospital. As for total protective equipment, I would say no. You see what they're doing in Italy and China, and I don't know if those precautions are overboard or not, because we don't truly understand how this virus is spread, if it's totally droplet or if it is truly airborne, because some studies suggest that it can stay airborne for 3 to 6 hours. Given we don't know that, I can't say for sure, but we don't have the full body hazmat suits that the other are using. We just have kind of some standard surgical type gowns that we wear, eye shields, and the N95s, and then gloves. So, I feel like we're adequately protected, given that.
But you don't know. It's probably just a lot you just don't know. Yeah.
Correct. But I haven't seen any of these nurses. And let me just give a kind of a shout out to the nurses. The nurses are in the rooms far more than I am, and they're the ones that are exposed to a far greater degree than I am. But I've not seen any of them get sick over the past probably month of protecting ourselves in this manner. And so I would tend to think that we are adequately protected.
Yeah. So and I agree with you with the nursing. I think it's, just to me, healthcare professionals really stepped up. What about protocols, treatment? If you're full, your beds are full, how are you treating people in general? What is working, maybe what's not working, and how long are they occupying those beds, or what's the process sort of moving people from maybe a triage situation to outpatient? Talk a little bit about kind of how that process is going.
Yeah, so I think for the triaging portion, that'd be better answered by one of the emergency room physicians that we have. We are staying out of the emergency department. They're kind of closed off their unit and they're doing their own thing. But from our standpoint, what we do is anytime we identify a patient that is in respiratory failure requiring intubation, we move them into a negative pressure room. We fully gown up with PAPRs. So it's not our typical PPE protocol that we're doing day to day. It's kind of extra on top of it, given the aerosolization potential with intubating someone. Move them to a negative pressure room. Everyone's in PAPRs, intubate them there. We give everyone a central line, which is a large bore catheter that we typically put in the neck, in the large vein in the neck. We give them an arterial line, so that an arterial line is just a way for us to monitor blood pressure in real time. So it's not like the cuff that squeezes on your arm. It tells us beat by beat what a person's blood pressure is so we can track it accurately. The reason that is these patients are requiring very high levels of sedation. I'm not entirely sure why they're requiring so much, but we are having to give them a lot of sedation so they're not fighting the ventilator, that is. So if they fight the ventilator, the risk for lung injury increases. So we're keeping them super sedated, and given we're keeping them so sedated, their blood pressures are dropping. So then we're having to give them medication to keep their blood pressures elevated. And it's a very fine dance that we're doing, minute by minute, hour by hour. We're reassessing these patients' blood pressure, sedation levels, and we're adjusting everything. It's a very time and labor intensive thing. And on a 12 or 24-hour shift, we're not leaving the unit. We're just constantly circling and making sure that everyone's optimized.
Yeah, just keeping check on vitals and things, and just keeping them balanced.
And then as for moving them out of there, that's kind of jumping kind of far down the line. But once we finally get these patients extubated, we get the tube out and we get them off of the ventilator, we're moving them to one of the dedicated COVID floors, and we're watching them, and we've had a very successful rate of getting these patients off of ventilators and getting them home and recovering at home. In fact, I was talking to one of the ICU attendings, and they said that part of the reason that we're getting so many transfers from the surrounding area is we've been so successful. I'm not sure if it's just the day-to-day management or any of the therapies we're doing. You had kind of touched on that. We're no longer doing the azithromycin standard with the hydroxychloroquine, which is a Plaquenil. It's a anti-malarial of all things. But what it does is it binds to the virus, prevents replication of the virus. And so there's been good success with the Plaquenil. We are actually currently doing a research study at my hospital. Myself, we have a very robust research division here at this hospital, and we've got 5 or 6 residents that are all in on this study, and we're trying to figure out what are we doing, management of their ventilator, the medications, the kind of day-to-day stuff that we're doing. Is any of that showing better numbers than what are being recorded elsewhere? And are we doing things that are helping people? Are we not? And it's all so early and new. That's what we're compiling right now. So we don't truly know if what we're doing is helping these people, because we don't have the numbers. We have numbers from Italy and China, but their powers are low, and some of the studies are not entirely, it's not entirely clear whether they're actually real powerful numbers.
So essentially it sounds like ventilation, helping them breathe, keeping their vitals normal, letting their body sort of normally fight this. Is there any kind of antibiotics or any kind of, I guess maybe that's the malarial type drugs. Those seem to work, and that lets the body kind of recover. Is that what you're seeing in general?
Well, yeah, essentially. So the hydroxychloroquine with preventing replication. We've got high dose zinc, high dose vitamin C. These are all showing to have some benefit. And antiretrovirals, Kaletra, remdesivir. There's lots of these antivirals and whatnot that are being researched, but we're not entirely sure. But what we do know is new research is coming out that the virus actually does not behave like or like how we've been treating it. We've been treating it like ARDS, acute respiratory distress syndrome, and that's kind of a byproduct of what the virus is doing. The virus is actually, it appears, is stripping the iron unit off of hemoglobin. So the iron units on hemoglobin are how the hemoglobin in your red blood cells transport oxygen.
Yeah.
So if you don't have that iron unit, that hemoglobin and the red blood cell cannot transport oxygen any longer. And you also have a free-floating iron unit that is causing oxidative injury, especially in the lungs. And so it appears that all of the lung injury is kind of a byproduct of the oxidative stress, not that the virus is actually targeting the lungs. Some of the current research is showing that initially we thought that the virus was entering the cells via the ACE2 receptor. Currently all the research is showing that it's not really binding the ACE2 receptor as strongly as we initially thought. And so it appears that a lot of this is injury due to the hemoglobin no longer being able to transport oxygen.
Is it the alveoli that are thin, that are permeable, that let the oxygen into the bloodstream, that are getting sort of a residue? Is that sort of how that works? It's the virus is damaging the ability for the oxygen to pass through those alveoli or stuff into the bloodstream? Is that sort of what we're talking about?
So kind of once again, taking a step back, is that's initially what we thought. That's kind of an ARDS picture, the
Right.
acute respiratory distress syndrome, where the alveoli end up filling with fluid, and you get a picture developed by lung injury. This appears to be, at least once again, we don't fully know, but what I've been reading and even experiencing is that it seems that it's all secondary to inability to transport oxygen in the red blood cells because of the virus stripping the ability to carry the oxygen. And then you're getting damage to the lungs because of that. It's a secondary byproduct. But what we are seeing is that these patients are getting extremely thick airway secretions. That's why people are having dry cough. When you say dry cough, it means you're not bringing up any sputum or any mucus. And it's likely that it's a dry cough, not because they're not making this mucus, but because it's so thick that they can't bring it up. So when we're suctioning patients out on the ventilator, the secretions are so thick sometimes that we have to change the endotracheal tube, the breathing tube, because it gets clogged. We just physically can't suction it enough to clear the thick mucus. So part of what we're doing, and part of what my hospital has been doing, is really aggressively hitting them with mucolytics. So, guaifenesin, Mucinex, Mucomyst, these things to try to break up this mucus and get ahead of it. Because when we try to take the tubes out of people so that they can breathe on their own, what we're finding is that they're struggling. And they're struggling and bringing up a lot of this thick mucus subsequently, and then we have to re-intubate them. So what we've really been proactively trying to do is stay ahead of the mucus, really try to break it down with these mucolytics, and we've had pretty good success with it. I don't know if, that's going to be part of our study that we're coming out with, to see if.
Yeah, that's odd to think of a dry cough with being overproduction of mucus. That seems counterintuitive.
I know it does, and that's why this virus is not behaving like a lot of what we've been seeing. Normally, people that have increased mucus production, they're able to bring it up, they're able to cough it up.
Yeah.
These patients are not, and I wonder how much of that is leading to their ultimate respiratory failure. Their mucus just gets to a point where they can no longer compensate for how plugged up their airways are.
Gosh. So I guess let's kind of finish on your research. Where do you see your research going? What are sort of the next things you're going to be doing? And then, of course, when we could get you back to talk about what you've learned, after you've had some time to study it some more. So where's your research go now?
Well, we're still in the data collection phase. We are trying to push this through extremely fast. Within the next week or two, we're hoping to get all the research completed, or the numbers completed, and then get a manuscript out. I see this being completed within the next 2 weeks or so. What this is going to tell us, we've had our infectious disease doctors here at this hospital have been kind of doing their own trials with remdesivir, and we're going to see what their numbers show. Once again, we stopped using azithromycin. We're going to have the numbers on the patients that we stopped using that on the patients that we continued all the other therapies. So I feel like this is going to be a pretty powerful study, given we have somewhere in the 600 or so range on patient numbers. So it's going to be a pretty good study, and you know, we've documented everything really well in our charts, thankfully. So we're gonna be able to draw a lot of information from these patient charts, and hopefully we get some numbers out there. We can start helping more people outside of our area.
Well, thanks again. I know you're burning the candle at both ends right now, but I really appreciate you joining us, and would love to get you back in a few weeks and maybe kind of do a follow-up on how things are going and what you're finding out, and that'd be great. And I really appreciate your time.
Absolutely. Thank you, Randy. And of course, once we get all the information from this study, I'd love to share what we find, because I'm hoping it's something good.
Thank you again for joining us. To subscribe to additional SMA podcasts, please visit sma.org/podcasts.